Hello, this is Cameron Sabat from Cutting to the Case, Conversations in Orthopedics. And today we have Dr. Charles Eaton, and he is a fantastic, he's a fantastic orthopedist, hand surgeon, now retired and serves on the board of directors at the Dupuytren Research Group. And he actually introduced needle aponeurotomy to the entire United States in 2003. We have a really major person on here today, and I really appreciate you joining the podcast.
Well, thanks for inviting me.
Thank you so much. So I guess my first question is, you introduced needle aponeurotomy to the US in 2003. What initially drew your attention to this procedure? And additionally, how did you navigate the early skepticism or potential barriers to its adoption?
Great question. I found out about the procedure from a patient who came in and told me that she had Dupuytren, she had a bent finger, she wanted to have it treated. She did not want to have open surgery for it, and she said that she wanted me to do the Paris procedure that she found out about online through a discussion group. People were going to Paris, having the Dupuytren treated and coming back, and they were all very enthusiastic about it. And she described it to me briefly about the doctor using a needle to release a Dupuytren contracture, and it sounded dumb and dangerous. And I looked into it, however, by looking at the discussion group that the folks were having on a bulletin board. And the reports that they had were remarkably enthusiastic, not like what you normally hear people talking about their experience of having a fasciectomy for Dupuytren. And I contacted the group in Paris that was doing this. It was a group of rheumatologists. I invited myself over, spent a week with them seeing this procedure, and then came back. And as it turned out, the person that asked me to do this on this group, they had been trying to recruit a doctor in the United States to do this procedure for some time, and we're asking people the question that I got asked. I was the first person to take the bait, and I quickly had my office was inundated with people who wanted to have this procedure done, and so I changed my practice to accommodate this, and I was really at the bottom of a funnel because I was the only person doing this in the States. And it was a scary thing because I realized if I had a major complication, there would be no one to step in at my malpractice trial to defend what I was doing. So I did it quietly on my own for a period of time until I was sure that it was legit and that it was something that wouldn't have an immediate problem with follow-up and early results. And I started that in 2003. And by 2005, I thought that it was good enough that I submitted a request for an instructional course at the Hand Society meeting. And that was when I rolled it out and invited people to come visit my practice so that they could see it in person, as I had. And that was it. Over years, I treated about 8,000 Dupuytren hands with this procedure, and so that's how I got going with it. The experience with it is what led me to set up this nonprofit advocacy group, because clearly the people weren't being they were an underserved group, and there were a lot of complaints from people about their doctor hadn't explained things to them. They really wanted to feel that they had some agency over their care.
Absolutely, and that's the stuff of legends. Truly inspiring to hear. And you did mention joining the board of directors after closing your clinical practice in 2012. You transitioned full time to leading the Dupuytren Research Group.
Right.
What prompted that decision, and how has your focus changed since stepping away from the OR?
Well, I'm the founder of the Dupuytren Research Group, and I established it while I was in practice as a general advocacy organization, because there wasn't any advocacy organization for Dupuytren. And so we set up some materials, patient education, trying to connect people with Dupuytren focused hand surgeons around the country. And as time went on, I have an issue with a tremor. I had to close my practice because of that, but I was still engaged with this. We changed the model from general advocacy to a traditional foundation model in which we did fundraising to give out research grants. And I went through one cycle of giving out research grants, and that taught me that the kind of research that needed to be done to change the trajectory of long-term Dupuytren outcomes wasn't being done. People were doing just the same kind of research that had been going on for decades and decades. And the realization of that, I realized, well, the kind of research that needed to be done, which was to develop preventive research, preventive medications based on biomarker guidance, if that research was going to get done, we were going to have to do it. And so we changed the name from the Dupuytren Foundation to the Dupuytren Research Group to reflect this new mission, and that's what we have been doing since. So.
Yeah, that's incredible, steering the course of an entire field. And we saw that reflected today with one of the prizes given to someone who worked in preventative in Dupuytren's. Yeah, absolutely. So also, as the founder of the International Dupuytren Data Bank, you've helped pioneer a crowdsourced research model. And what are some of the most surprising or promising insights that have emerged from this data set so far?
We are still analyzing the data. The interesting thing is that typically Dupuytren is, it's more common in men than women, at least in younger people. In the International Dupuytren Data Bank, it's slightly more women than men who are participants in this. And we have been exploring different ways to assess clinical factors on just a patient-reported basis. And so one thing that we've done is to get an idea of how bent fingers are. We have some qualitative evaluations about the subjective impact of Dupuytren on people, social and functional, and also how bent their fingers are. And what we've been doing with that is to have a simple diagram of a lateral view of the hand and have people indicate based on 4 choices in the Tubiana scale of how bent is their most bent finger. And that is I think a useful metric because excuse me, that is how fast the disease is progressing. And I think that in doing simple measurements, that is something that we could do. We have been looking at rates of progression of when the person first noted they had Dupuytren and how bent they are now to be able to calculate a rate of progression. We're still going through that data. We have currently about 7,000 enrollees in this. Not everyone continues. One of the lessons learned is that you can set up a registry and people will sign up and not necessarily continue with the follow-up surveys. The thing that, the biggest lesson I think is that initially it's good to not reinvent the wheel. And we partnered with the Arthritis Research Center who had been doing patient registry work for some time, self-reported information on people with rheumatologic disorders. So we used their infrastructure. There is, I think, better, more convenient technology now to be able to use, to have a phone app that would, say, query you on a monthly basis or allow you to put in information ad hoc rather than waiting for your 6-month review. And that, I think, ultimately is where we're going to go with that.
Yeah, and you're very in touch with technology as well, if you're going as well into phone apps and screenings and preventative research and all of these other avenues that haven't been traditionally explored in this world of research. So you've actually long emphasized the need for preventive biologic treatments as well for Dupuytren's disease. Where are we now in that pursuit, and what's holding the field back from a disease-modifying breakthrough?
The biggest thing that's been holding the field back is a problem that the research is siloed. So the people that treat Dupuytren are surgeons. Dupuytren is a chronic progressive disease, and you can only develop effective preventive treatments for a slowly progressive chronic disease by using biomarkers as a trend analysis, so you can rapidly measure therapeutic response. Right now, if we had a medicine that could, or a treatment that could prevent progression, we know that people that have early disease just have nodules. 10% of the nodules will resolve on their own, and over the next 10 years, only 20% will progress to contracture. So if you take that data and you do a power analysis on it, if you had a medicine that you thought would prevent progression from nodule to contracture, you'd have to excuse me, you'd have to do a 5,000 patient year observational study of 500 patients with your treatment, 500 placebo, and then follow their measurements over at least 5 years to tell if you had an effective preventive action. This is the kind of numbers that any chronic disease prevention research faces. And so the workaround that our medical colleagues have come up with is biomarkers. And so the whole idea is to try to identify a biomarker profile that excuse me, correlates with the diagnosis is the first step, and then advance that to a biomarker panel that correlates with prognosis, a staging biomarker, and then use that to see if you can measure drug response in real time. So we launched a proof of concept pilot study on Dupuytren using patients that were recruited from the International Dupuytren Data Bank. And we were able to target people I'm sorry, that have high diathesis scores, people with at least 2 first-degree relatives with Dupuytren, age of onset younger than 50, and at least 3 active areas of Dupuytren disease. So it's actually only about 5% of our Dupuytren patients meet all those criteria. We had those versus control patients that had no Dupuytren in the family. And we got blood samples on both of those, did a series of different proteomic analyses and a series of different genomic analyses. The proteomic paper is been submitted. We're currently waiting on that, and the findings from that are one, that we did some collagen metabolite markers and found that in Dupuytren disease, unlike other chronic fibrotic diseases, collagen synthesis appears to be normal. The markers of collagen synthesis are not elevated, even though there's collagen accumulation in Dupuytren. We found that there is an impairment of collagen degradation. So this makes Dupuytren stand out as a unique fibrotic disease, because in other fibrotic diseases, pulmonary fibrosis, liver fibrosis, there's an increase in degradation, but there's an even greater increase in synthesis, and this is different than that. So that's a potential marker, and that's a potential lead for what we need to do, because the therapeutics that have been discussed over the years have been how to reduce collagen synthesis, and that, I believe, is the wrong target. We need to figure out how to increase collagen degradation. The other wing of the study was doing a large-scale proteomic discovery. We looked at 7,000 proteins in the blood, and from that developed 2 different proteomic risk scores that could distinguish people with Dupuytren versus those without. And so that's a diagnostic panel. And then in a small subset, one of the scores was able to distinguish people who had their first procedure younger than 50 versus older than 50, which is a staging metric, because people that develop their disease earlier tend to have more severe phenotype. So that's where we currently are. This is a pilot study. We need to replicate this on a larger scale. We also need to get it published. And then the genomic information, we have whole exome DNA, whole genome, epigenetic tests, bisulfite sequencing, and mRNA and small RNA. And that will be able to cross-correlate with our proteomic findings. So I'm very excited that we'll be able to have a bit of information that we can repeat on a larger scale and come up with a useful panel.
Yeah. And in building that useful panel, we're inching ever closer to patient-specific treatments
Absolutely.
instead of
Yeah,
just
absolutely.
general.
Yeah. So Dupuytren is genetic, and it's an interesting thing because when you look at the numbers, the inheritance is very strong with Dupuytren. The child of a parent with Dupuytren has about a 50% likelihood of developing Dupuytren themselves. And you'd think, well, that's clearly an autosomal dominant inheritance, which describes a single gene disorder, but Dupuytren is clearly polygenic. And so I think the deal is that the overall risk is so high that even different combinations of at-risk genes are so common that you have this very common inheritance. But I believe that Dupuytren is likely a phenotypic convergence of different starting points, just like diabetes. You know, there's all these different kinds of diabetes, and it's not helpful to talk about diabetes as if it's one disease. It's a phenotypic convergence of other risks. So personalized medicine is clearly the way to go for this, and you can develop a biomarker panel to see which areas of Dupuytren are dysregulated, and when we get to the point of having genetic treatments, not CRISPR, but silencing RNA treatments, then we can tailor those to your phenotype of Dupuytren.
Absolutely, yes. And in so doing, in bringing the care to the patient, you've additionally maintained this philosophy in your outreach efforts for information and rapid dissemination of information. In fact, they've made scientific information on Dupuytren's accessible to thousands of patients worldwide. And what role do you think that physician-led education plays in shaping public engagement and research progress, especially in a world so strongly formed by maybe social media influencers or misinformation online?
It's a complex problem. I think the key thing is that doctors and patients have to work closely together. And the problem with Dupuytren has been for a long time that the patient has been just a passive part of the whole Dupuytren treatment model. And the difficulty is that we don't have good metrics to assess hand function as a baseline because we measure finger angles. Angles don't really correlate well with function because there's a lot of adaptability and redundant function in the hand. And ultimately, the patient doesn't care about the angles. The angles are unimportant. What the patient cares about is how their hand works, how awkward it is, how awkward they look in public. People are very self-conscious about their hands. You know, your hands and your face are the only parts of your body that other people routinely see, so they carry a lot of psychological and personal image impact. And so if someone is awkward in the way they use their hand, it draws your eye to the hand. If someone has a major problem with their hand and uses their hand normally, it won't catch your eye at all. You probably have met people who have a finger amputation and you never noticed it because they use their hands so normally. So the self-image and just the personal feeling of how someone's being perceived by others is a big thing. And so these are two areas that are not matched. The patients know what they want, the doctors know what they can provide, and in order to get the proper word out and combat misinformation, I think there needs to be a larger stream of information from an organized group of doctors and patients.
And yes, I really appreciate that. And the stigma approach you took to that was particularly interesting. I studied stigma. I was a religion major back in college.
Oh, yeah.
What we studied a lot was the stigma within religious groups of various medical conditions. And I did a master's in religion, so I studied bioethics. One thing we really discussed was in oculoplastics, for instance, nystagmus. When in films, when there's a convergence, or there's some level of mental challenges associated with characters where their eyes aren't pointed straight, and the same goes for a lot of other things such as diabetes or weight or even hands, having them contorted,
or even cleft lip. It's not
actually a major functional problem for most people with a cleft. But it has huge social impact.
Oh my goodness, yeah. I mean, imagine running for a presidency of some organization or
Yeah.
even the United States with
Yeah.
a cleft lip.
Yeah.
I mean, that would be the only thing that's discussed on national media.
Yeah.
So
Yeah.
it's exceptionally important, and I appreciate all that you do. Now, I wanted to be mindful of your time as well, so I wanted to bring this to the last question, which is arguably the most important for our audience as well, which is, what advice would you give to the next generation of hand surgeons or clinician researchers who want to make a difference in a field with historically limited awareness, funding, or treatment options, of which you've been doing so much to fix?
Yeah. Well, the first thing is listen to your patients, and it's difficult to do because we're all trained to get things done, and it requires not moving as fast, and patients who take a lot of time to kind of peel the layers of the onion back is worth it. And if someone has a crazy idea, don't dismiss it out of hand. Look into it a bit, and then you can dismiss it. But just like with this, I never would have gotten there, and I was I think I was the 6th doctor that this patient had met and proposed that they learn this procedure, and she was just one of many others doing that. So just listening to her really changed the whole thing. I think in solving an impossible problem, there are 3 things you can do. One is question convention, and don't assume because things are really established that's the way to do. Examine failure in being brutally honest of trying to think of all the different reasons why whatever you're doing isn't working out the way that it should be, or why this particular problem is such a big problem. And the third and most important is engage outsiders, because they will have ideas that you will never come up with. And so cross-disciplinary pollination is key. But those 3 things I think are the go-to for any problem which just seems entrenched and you don't even know where to start.
Yeah, look outside the field, into the
Yep.
periphery.
Yep.
And
Yep.
you know, well, I know that was the last question, and that is the last question, but I just wanted to comment on your double training in general surgery and plastic
Yep.
surgery,
Yep.
and how that multidisciplinary approach shaped your background and your approach to these complex fibrotic diseases. And I really appreciate all the work that you do. I'm so honored to have you on this podcast. I'm sure that our listeners are well appreciative too.
Well, thank you very much. This is an honor for me.
Of course.
And,
Thank you very much, Dr.
all
Eaton.
right, great.
So this is
Thanks.
Cameron Sabat on Cutting to the Case, signing off.